for having me.
Are we on, Sanish?
Yeah.
Can you hear me?
Yes, please.
Hello, can you hear me?
Yeah.
Yes.
You can proceed.
Hello, can you hear me?
Yes.
Hello.
Hello, can you hear me?
Yeah,
Yes.
we can hear. You can proceed.
Can you put the screen for the meeting?
I think Dr. Kumar Belani, you can start proceedings.
Okay. Good morning, everybody, and welcome to this special webinar conducted by the Indian College of Anesthesiologists. Today's topic is congenital heart disease, and I would like to begin by sharing my screen to show you who was the person who started open heart surgery in the world. And you can take a look at my screen now in a minute. And you can see here now the father of open heart surgery. It was in Minnesota. He was a Minnesotan, and he did the first open heart surgery in September 1952, and this was an adult. But the first pediatric case was actually done a little bit later in 1954, and this was a historic operation at the University of Minnesota, where this 13-month-old child had his VSD repaired while the father provided the cross-circulation bypass pump. And from then on, we progressed quite significantly, and we will go on now to this webinar. Our first speaker is Dr. Martina Rixfield, and she is an assistant professor at the University of Minnesota. She is a pediatric anesthesiologist and is also director of our pediatric cardiothoracic anesthesiology program. And she's also the director of a pediatric anesthesia fellowship program. She got a medical training in Germany at Technische University, and then she came to the United States where she did a residency at the University of Minnesota in anesthesiology. And then she went on to do pediatric anesthesiology at the Tufts Medical Center in Boston. She also has done a research fellowship at Massachusetts General Hospital and Shriners Children's Hospital in Boston. She's interested, obviously, in pediatric cardiac anesthesia, but also in blood transfusion management, blood product conservation, and quality assessment and improvement. She's going to talk to us about acyanotic congenital heart disease, their classification. Martina, please take over.
Thank you, Dr. Bellani, for this kind introduction. Can you all hear me?
Yes, yes,
Great.
you can proceed.
I will go ahead and share my screen. All right. Can you see my screen?
Yes.
Great. So it is my pleasure to talk to you today about classification and pathophysiology of acyanotic heart disease. A brief outline of this presentation is that we first talk about the overall classification of acyanotic heart disease. Then we'll briefly go over the definition of left to right shunt, talk about the implied pathophysiology that results from left to right shunts, and then go over the most important cardiac lesions that have left to right shunts involved with them. So the overall classification of acyanotic congenital heart disease can be divided into lesions that have left to right shunts. And examples for these would be atrial septal defects, ventricular septal defects, atrioventricular canal lesions, a patent ductus arteriosus, as well as an aortopulmonary window. We will talk about most of these lesions later on a little more in detail. And then the other part of acyanotic congenital heart disease lesions are outflow tract obstructions. And those would include congenital pulmonary valve stenosis, congenital aortic valve stenosis, as well as coarctation of the aorta. As 15 minutes is kind of like a short time, I will focus on the lesions with left to right shunts and their pathophysiology. So what actually is the definition of a left to right shunt? It means that oxygenated blood shunts into chambers or vessels that normally carry deoxygenated blood. So the prerequisite for a left to right shunt is that there is a connection between the right and the left-sided chambers or vessels of the heart. And right and left typically does not refer necessarily to just the anatomic location, but more so, as I mentioned before, to the presence of oxygenated or deoxygenated blood. So when we talk about left structures, we mean structures that carry oxygenated blood. And when we talk about right structures, then we refer to structures that typically carry deoxygenated blood. So what is the physiology behind a left to right shunt? So it really follows very basic physical principles, as blood always flows along the path of least resistance. The resistance is the thing that determines the direction of a shunt, and the difference in pressure, called the pressure gradient, determines the velocity of a shunt between two chambers. So with blood shunting from the left-sided structures to right-sided structures, there basically results a increased pulmonary blood flow, which can actually result in increased pulmonary vascular resistance and eventually in the development of pulmonary arterial hypertension. With this shunting blood volume that is not going along the typical path, which would be basically staying on the side of the heart, which carries either deoxygenated or oxygenated blood, but mixing of this results in a volume overload for the heart, which is seen as cardiomegaly on imaging exams like a chest x-ray or echocardiography, and then can potentially result in congestive heart failure. Due to the dilation of heart structures like the atria or the ventricles, it can result in dysrhythmias as well as myocardial ischemia. The reason for myocardial ischemia would be that there can be, due to the volume overload, increased end diastolic volumes and pressures, and that does impair myocardial perfusion and therefore can lead to myocardial ischemia. So let's go into some of these lesions that have left to right shunts. The first lesion that I want to go into are atrial septal defects. Atrial septal defects are about 5 to 10% of all congenital heart defects. And they are basically classified by their location in the atrial septum. The atrial septum consists of basically 2 layers that form during fetal development, and it's the septum primum and the septum secundum. And if the fetal development has some abnormalities to it, these atrial septal defects can result. So, and a primum atrial septal defect involves the primum atrial septum. A secundum atrial septal defect involves the area of the fossa ovalis and basically results from abnormal resorption of the primum atrial septum. And then there is more rare atrial septal defects like sinus venosus atrial septal defects, which are in the area of the sinus venosus close to the entrance of the SVC or the IVC into the right atrium. And then another lesion that is fairly rare are coronary sinus atrial septal defects which involve the coronary sinus. So the most frequent atrial septal defects are secundum atrial septal defects, and they include mainly almost 80% of all ASDs. Isolated ASDs are more common in females with a ratio of around 2 to 1. So an atrial septal defect causes a left to right shunt, mainly based on the different compliance of the 2 atria. The left atrium is typically less compliant than the right atrium, and therefore during diastole, there is flow from the left to the right-sided atrium. There is a small pressure gradient as well, but the pressure gradients on the atrial level typically are rather low. So the shunt fractions based on this are oftentimes not significant, and therefore an ASD can often be asymptomatic during infancy and childhood, and results mainly in an increased volume load to the right ventricle. The amount of the left to right shunting depends on 2 factors. One is the size of the defect, and as I mentioned before, the second factor is the relative compliance of the right and the left ventricles, which translate into the compliance of the right and the left atrium. If congestive heart failure occurs, it typically only occurs after the 2nd or 3rd decade of life. When congestive heart failure occurs and there is significant volume load for the right ventricle and increased pulmonary blood flow, pulmonary hypertension can occur in up to 13% of patients that do not get treated for the atrial septal defect. And that typically happens in older infants and children. Due to a distension of the right atrium, there can be an increased risk of arrhythmias. The next lesions that involve left to right shunts are ventricular septal defects. Ventricular septal defects are the most common congenital heart defect. And 50% of all children with congenital heart disease have VSDs. It's important to understand that all the lesions that I'm talking about today, they do not necessarily appear as isolated lesions, but can be combined lesions with other defects. About 20% of all VSDs are isolated lesions. And as I mentioned, they can be in combination and are associated with a variety of inherited conditions. So increased volume load, again, occurs with the left to right shunt that we see with ventricular septal defects. They can be restrictive or non-restrictive, and that is basically related to the size of the ventricular septal defect. Non-restrictive ventricular septal defects are typically larger in size and therefore have a larger shunt fraction. Symptoms of congestive heart failure by the age of 3 months. If these lesions are not corrected and the left to right shunt and the resulting volume load on the right as well as the left ventricle, and with that increased pulmonary blood flow, can cause pulmonary hypertension that over time will actually result in irreversible changes, and that can lead to so-called Eisenmenger syndrome, which may develop by the age of 2 years if the lesions are not repaired. Eisenmenger syndrome refers to the fact that the pulmonary arterial blood pressure and pulmonary vascular resistance becomes higher and higher, and therefore limit the shunt fraction, and eventually can even reverse the shunt from a left to right shunt to a right to left shunt. On the other hand, actually most VSDs are not going down this very detrimental path, but about 50% of VSDs that occur in the muscular septum or small VSDs that occur in the perimembranous septum can actually close spontaneously. The third lesion that I quickly want to touch on are atrioventricular canals. Atrioventricular canals are is a failure during fetal development of the endocardial cushions to fuse. So if these cushions do not fuse, then we have a defect in the atrioventricular septum, which results not only in basically an ASD and a VSD, but in addition to that, in a deficient separation of the tricuspid as well as mitral valve, and eventually the formation of a common AV valve. These lesions, as you see on the images on the left, can present as partial AV canal defects, as transitional or complete AV canal defects. A partial AV canal defect typically consists of a primum ASD, a cleft in the mitral valve, though a separate mitral and tricuspid valve, and no ventricular septal defect. Transitional AV canals have a primum ASD. They still have 2 separate atrioventricular valves that are typically, though, incompetent, and on the left side do have a cleft in the mitral valve and have a very small VSD, typically right below the atrioventricular valves, which is called a small inlet VSD. A complete AV canal consists of a primum ASD, a fairly large inlet ventricular septal VSD, as well as a common atrioventricular valve. AV canals are associated with multiple syndromes. The most important to keep in mind is trisomy 21. They are separated into different complete AV canals, sorry, I should have said that, are separated typically by the formation of the common AV valve, and result in different types that are important for their surgical repair. In the interest of time, I'm going to just skip over this and talk briefly about AV canals and the pathophysiology, which is very similar to the pathophysiology of VSDs. And basically, the most important thing to keep in mind in regards to AV canals is that it's not only a left to right shunt at the ventricular as well as atrial level, so shunting on two levels of the heart, but in addition, oftentimes the atrioventricular valve is regurgitant, so there's a regurgitant fraction of blood that flows backwards to the atrial level, so even more volume overload for the heart. So the severity of the congestive heart failure and the symptoms that are resulting will depend on the degree of the left to right shunting as well as the severity of the AV valve regurgitation. Pulmonary hypertension may develop by 1 year of age, and therefore these defects are typically repaired around the age of 6 months or even earlier if congestive heart failure occurs earlier. And it's important not only to understand that these oftentimes occur in patients with trisomy 21, but that patients with trisomy 21 have a tendency to develop pulmonary hypertension earlier and with increased severity. The last lesion I would like to touch on is a patent ductus arteriosus. And that means that a connection between the aorta as well as the pulmonary artery persists after a child is born. This connection is very important during fetal life, as we all know, but typically closes within about 24 hours after birth and functionally permanently closes after a few weeks of life. Isolated PDAs are seen in around 1 of 2,500 to 5,000 live births. The incidence is significantly higher in premature birth, and it's 2 to 3 more common in females. This connection that persists between the aorta and the pulmonary artery, again, causes a left to right shunt that this time is at the level of the great arteries. And the degree of shunting depends on the size of the PDA, which involves on one hand the length and on the other hand the diameter. And the other determinant of the degree of shunting is the ratio of the pulmonary vascular resistance to the ratio of the systemic vascular resistance. So shunting of blood that leaves the left ventricle into the aorta back into the main pulmonary artery will involve only the left-sided structures of the heart, as the shunting blood does not actually enter the right-sided structures of the heart with an isolated patent ductus arteriosus. So what we will see is an increase in left atrial and left ventricular size and volume. The other significant difference between a ASD and VSD versus a shunting at the arterial level is that at the arterial level, we can actually see diastolic runoff into the pulmonary vasculature as well. And that can result in lowered diastolic aortic pressures and again, impair myocardial perfusion. So with left to right shunt lesions, not only can myocardial perfusion be impaired by the increased end diastolic volume or end diastolic pressure, but as well, when the shunting appears on the level of the great arteries, it can be impaired by diastolic runoff and therefore decreased aortic diastolic pressures. I think I am right on time, so I will end my presentation here and be happy to answer questions at the end of the webinar. Thank you very much for your attention.
Thank you, Martina. That was wonderful. And if Dr. Muralidhar, are you around, sir?
Yes, as I got connected, I lost the connection in between. I'm sorry about it.
I started this in
It's a
meeting and
Yes.
didn't introduce
Thank you for
myself.
that.
I'm Professor Belani. I'm one of the honorary international deans of the Indian College of Anesthesiologists and professor of anesthesia,
Yes.
chief of pediatric anesthesia at the University of Minnesota. So Dr. Muralidhar, back to you now, sir.
Thank you, Dr. Belani, for taking up this, starting this webinar. I'm grateful to you for that. Quickly, we'll move on to the next section of the webinar, that is the cyanotic heart disease in children. Very important topic. We get patients coming not only for cardiac surgery but also for non-cardiac surgery. So we'll go into the pathophysiology of cyanotic heart disease, and we have Dr. Hema Nair, who is a bright and brilliant anesthesiologist, who is my colleague, and she's very experienced in this field. I would like to ask Hema Nair to tell us about the pathophysiology of cyanotic heart disease in children.
Thank you, sir, and thank you, the office bearers of ICA, for having given me this opportunity to give this talk on the pathophysiology of cyanotic heart disease. I'll share my slides right now. So this is the talk. I'll be talking about the pathophysiology of the cyanotic heart disease. Cyanosis is a scientific term for blue babies. I think we are all aware of that. Just to get into the nitty-gritty of it, it's when the saturation is less than 90%, 91%, that we call them cyanosed. This happens primarily because of low blood flow to the lungs. So the cardiac output of in a normal person is equal on the right and the left side. Here, it's less on the right side and more on the left side. And whatever should have gone into the lung is now actually going into the systemic circulation. So the systemic circulation has blue blood. That's simply put. Coming to the altered anatomy that we see, the congenital cyanotic heart diseases are, like I said, right to left shunt, the commonest one of which is the tetralogy of Fallot. It has 4 components, a VSD, an aorta which is overriding, as in it faces the RV and the LV over the VSD, and right ventricular outflow obstruction, which causes resistance to the right ventricle to eject into the pulmonary artery, but most of the blood therefore goes through the VSD and into the aorta, and therefore you have blue blood coming into the circulation. The other lesions are pulmonary atresia or tricuspid atresia or a double outlet right ventricle. I'm not going into the details of the altered anatomy here, but suffice to say that less blood is going into the lung, and through some intracardiac shunt, this blue blood is going into the left side and out into the aorta and the systemic circulation. You see cyanosis also in some of the mixing lesions or mixing disease or in diseases which have recirculation, like a total anomalous pulmonary venous connection, as well as a great arteries. In transposition of great arteries, the circulation is in parallel, not in series like in a normal person. And the cardiac output is maintained, and indeed life is maintained by mixing within the cardiac chambers at different levels, either at the atrial level or the ventricular level or through the PDA. In total anomalous pulmonary venous connection, all the pulmonary venous return is coming into the right side of the heart. And from there, only after almost near complete mixing, are we getting any cardiac output into the left side. Now, the pathophysiology of cyanosis is primarily due to the hypoxia. And it could be compensatory mechanisms by the body to improve the hypoxic state and overcome the lack of oxygen. It could be due to the complications of the abnormal physiology or the complex or the altered anatomy. I shall one by one discuss the pathophysiology that we see in blue babies or blue patients. Cyanosis is, as an absolute entity, it is per deciliter of deoxygenated hemoglobin circulates in the blood. So apart from the relative concentration, the relative ratio between the deoxygenated and oxygenated blood, it is also the absolute amount. Therefore, if the patients have a higher hemoglobin, they are more likely to be cyanosed. For instance, an absolute value of more than 3 grams % is needed for the baby to appear blue. Say in a patient with 10 grams hemoglobin, even if they are 75% saturated, the deoxyhemoglobin content is only about 2.5%. So they clinically don't appear cyanosed. At the same time, this very baby, if the hemoglobin is 16, then the percentage of deoxyhemoglobin is 4, and therefore they appear cyanosed. So that is something to keep in mind. The baby will appear blue only if the hemoglobin is normal or above normal. And it's obviously central cyanosis. So it is seen in the mucous membranes, and not just in the periphery of the hands and feet. So pre-cyanotic rubra is something which we see in babies with right to left shunts, but if they are anemic. So if they have hemoglobin which is 10 or less, they may be cyanosed. They may be hypoxic, but because the content of deoxygenated hemoglobin is not going higher than 3 grams, they have a darkish pinkish tint to their skin. So they don't appear blue, they actually appear pink. So that term is called pre-cyanotic rubra. It is important to suspect that they could actually have a right to left lesion and get an echo done, even if they don't appear clinically very blue. So just a word about differential cyanosis. It's just an interesting entity. Because of the particular nature of the shunts and the obstructions that are happening at different levels, you can have a certain situation where the lower body is blue and the upper body is pink. This happens in instances where there is an aortic obstruction and the lower body is perfused by the ductal circulation through the patent ductus arteriosus, and the flow from the PDA is right to left because of the aorta being obstructed. In this case, the blue blood flows through the PDA into the lower body, but the upper body continues to get pink blood. So you can, if you put pulse oximeter on the upper limb and the lower limb, you will see that is a differential cyanosis. Now the reverse happens in a transposition of great arteries, because in transposition, the LV gives rise to the PA and the RV gives rise to the aorta. And the PDA is again flowing right to left. Therefore, the lower body will have bright blood, but the upper body will have deoxygenated blood. Coming to the most obvious clinical feature that you see in a cyanotic child, it's clubbing, and it's because of hypertrophic osteoarthropathy. It is more evident in babies who are older than infants. More than 6 to 12 months after hypoxemia is when you typically see clubbing happening. It happens earlier in the toes than in the fingers, probably because of more hypoxic blood getting to those peripheries. It is also seen earlier in thumbs. Now, the good thing is that if you treat the cyanotic heart disease, clubbing is reversible. Erythrocytosis is another clinical feature. This is because hypoxia leads to increased erythropoietin production from the kidneys. That in turn stimulates the bone marrow to increase RBC production. RBC is produced at the expense of all the other blood components. And the longer the baby is cyanosed and the more the degree of hypoxia, more is the polycythemia. This is actually a defense mechanism of the body, because since the baby is hypoxic, this is an attempt to increase the oxygen content of whatever blood there is so that more oxygen gets to the tissues. Now, since the erythropoietin stimulates the bone marrow for RBC production, one of the essential substrates is anemia, is iron stores. So if with more and more RBCs being produced, it's likely that the bone marrow gets depleted of the iron stores, and then they can have something called a relative anemia. For the degree of hypoxia, the hematocrit or the PCV is less than what it should be. They then manifest with poor exercise tolerance or cardiovascular accidents. They can have hypocyanotic spells, and they should be treated with iron supplements. Oftentimes when we come across tetralogy babies, they will be on oral iron supplements so that they don't go in for relative anemia. Erythrocytosis is, although it is a protective mechanism, if it goes too far, it is a problem because it changes the blood rheology and flow through the capillaries becomes sluggish, and tissue hypoxia can still result. Polycythemia is the further side of the spectrum of erythrocytosis. Once the PCV rises to above 60%, this whole thing is counterproductive. It is not helping anymore. The viscosity is so high, the blood is so thick, and RBCs themselves are subject to a lot of shear stress, and you actually have an increase in peripheral vascular resistance and a fall in cardiac output. This is seen mostly in older children and young adults. They have headaches, cramps, chest pain, very easy fatigability, irritability, and they can also have strokes. The treatment previously, which was advocated for this, was phlebotomies. But now we know that phlebotomy is not the answer because it depletes the iron stores of the patient. And once the blood is taken out, the bone marrow just gets stimulated to produce more RBCs. So the better option would be a erythrophoresis. I think I've spelled this wrong here. It's erythrophoresis, where in a graded manner, small aliquots of blood is taken out and replaced with plasma, therefore decreasing the viscosity. Blue baby is often present with cyanotic spells. This is seen more in the younger patients and primarily in tetralogy, because here you have a very reactive right ventricular outflow tract. You have the septal and the parietal muscle bundles in the right ventricular outflow tract, which responds to stress by constricting. So when the babies are stressed, if they're in pain, uncomfortable, or crying, the infundibular spasm kicks in and the RVOT is almost nearly blocked. All the blood now shunts across the VST and goes out into the aorta, and therefore they appear much more bluer than they normally are. Now, since it is a reactive situation, it is seen mostly in babies who are otherwise pink looking. So you have to worry about these patients because normally these babies are pink. Their saturations are not very low. It will be somewhere in the high 80s or early 90s. And if they go into a cyanotic spell, one needs to worry because this physiology is not used to having such levels of hypoxia. They don't tolerate it very well. On the other hand, the babies who are always blue, they have responded with polycythemia. They have a much larger range of tolerance. They can tolerate cyanosis much better. Their organ systems can tolerate it. When they have a cyanotic spell, they can be tachypnic. You have deepening cyanosis. It can even go as far as syncope and shock. And if it's severe and persisting and it is not treated, it can go on for seizures, stroke, and even arrest. This is a little figure which shows the mechanism of this cyanotic spell. Primarily, you have a stress happening. This leads to an increased oxygen demand. Babies respond with hyperapnea, tachypnea, and this causes a decrease in the mean intrathoracic pressure. Systemic flow is increased and pulmonary flow is compromised, increased right to left shunting, and then that again goes into this vicious cycle. Something that you can use to break this vicious cycle is administration of opioids to calm the baby down, deal with the stress, and which hopefully opens up the infundibular spasm. Also, increasing SVR may help because if the SVR is higher, blood can again be into the pulmonary circulation. If the babies are awake and not anesthetized, you can put them in the knee chest position, or if they are around 2 to 3 years of age, you can see them squatting. The idea being to compress the femoral and the popliteal arteries, which in turn increases the SVR and reduces the right to left shunt. Humidified oxygen can be administered if the babies are being treated in the ICU, but because it is primarily the problem is right to left shunt, it is of limited benefit. You can give it a try if the saturations are very low, because at least some amount of dissolved oxygen can get into the tissues. But if attempting to put on the oxygen mask on the baby makes the baby cry even more, it would be advisable to not persist with that line of treatment and just let the baby be sedated and let them sleep, because that would help them much more than struggling to put an oxygen mask on them, which they are fighting to get off. Opioids morphine can be started as an infusion to calm them down. And you can try to increase the SVR by pharmacological or physical means. By pharmacological, I mean vasopressors like noradrenaline or phenylephrine. And physical, as in if you have a patient on table undergoing cardiac surgery, and before they are able to go on bypass, if you have a severe bout of swelling, then you can ask the surgeon to either compress the femoral artery from the outside or partially clamp the aorta in an attempt to increase the SVR. The other means of dealing with a cyanotic spell is to make sure that they are not hydrated or dehydrated, or hydrate them adequately, and deal with acidosis by administering soda bicarb. Beta blockers, like I said earlier, helps with relieving the infundibular spasm. Now, in cyanotic heart disease, as the disease progresses, you have neurological sequelae. One of the most dreaded ones is a cardiovascular accident in terms of stroke. The reason for this is a thrombosis. Because of the thick viscid blood within the vasculature and stagnation, they thrombose. And this thrombosis, these thrombus can embolize. This is made worse by dehydration. And it is also seen in relative anemia, because in relative anemia, already the cerebral circulation is getting very little oxygen. And it can manifest as stroke or seizures. You deal with it by avoiding dehydration and trying to reduce the viscosity of the blood, particularly in older children, by erythrophoresis, like I mentioned earlier. The ultimate definitive treatment, obviously, is to try to increase the oxygen content of the blood by a shunt or a corrective surgery. By shunt, I mean a created systemic pulmonary shunt, which provides more blood to the lung vasculature. Another neurological sequelae that we see in long-standing cyanotic babies is cerebral abscess. The problem here is that the venous blood coming from the rest of the body is shunting across the VSD and getting directly into the aorta. So it bypasses the pulmonary filter. The lung circulation is very well endowed with defense mechanisms, and this blood from the venous system has now access directly to the aorta and to the body. So in the brain, like I said earlier in the previous slide, you have pockets of ischemia in the brain because of less blood supply there, leading to small areas of infarction, and where there is liquid brain matter in small little pockets, particularly in the watershed areas. Into that area, if you get some kind of infective material which has bypassed the lung circulation, you have a sterile abscess which subsequently gets infected. This is seen mostly in older children, young adults. And if you have a blue baby which suddenly develops a fever, is very irritable, has a fit, then you should suspect a cerebral abscess. One should not do an LP in this lumbar puncture in these babies unless high ICP is ruled out. Otherwise, they will have a coning because of the increased supratentorial pressure. Diagnosis confirmed by CT scan or MRI, and the treatment is long-term antibiotics. Sometimes you have to do a burr hole and aspiration of the abscess. A note here to the anesthetist who may come across these babies: it is very kind to put in a fairly long-term intravenous line in these patients, like a PICC line or an anticubital long vein, long catheter, because it's miserable to see them being poked for 3 weeks to get antibiotics. If you put in a peripheral line, it's gone in a couple of days, and the antibiotics are pretty strong. It would be a good idea if you have a baby with cerebral abscess in a cyanotic baby, if such a baby comes into your care, to have a line put in which can last at least a week to 10 days. The other problem is coagulopathy. Now, I said earlier that you have polycythemia and all the blood marrow, the whole bone marrow is concentrating on providing RBCs, which follows that you have very few platelets and whatever there is are dysfunctional and they don't form clots very easily. Also, the PCV is somewhere in the range of 50 to 60% or even 70%. And that means the volume of plasma is compromised and therefore the clotting factors are compromised. Intravascular thrombosis means that the clotting factors are consumed within the vascular compartment itself, and there's not much left to form clots in case of injury. They also have decreased fibrinogen and increased fibrinolysis. So the recommendation is if these babies come for small surgeries or dental extractions, you should do a full screen of the coagulation parameters before taking them up.
Emma, how long will you take? How many more slides?
Last one.
Okay.
Hyperuricemia seen in older patients and adults. This is because of long-standing polycythemia and increased red cell turnover. It's treated with allopurinol and it is reversed by corrective surgery. Thank you.
Thank you, Hema, for that brilliant talk on cyanotic heart disease and pathophysiology. Thank you so much. Now I will request Dr. Lokesh, who is a consultant in Rainbow Hospital, deals with a lot of children, to talk about non-cardiac surgery in congenital heart disease. Suppose you get a patient with congenital heart disease coming for non-cardiac surgery, what should be our approach? Dr. Lokesh, please. Dr. Lokesh, are you there?
Yes, sir.
Yes.
Can you hear me?
Yes, I can hear you.
Hi, good evening, everyone. Hello.
Yes, good evening.
Yeah, thank you for giving me this opportunity to. Thank you.
Muted now. Lokesh, yeah.
Yeah, good evening, everyone. Thank you for giving me this opportunity to speak about this anesthesia for patients with congenital heart disease. Just a minute, I have problem sharing my screen.
There you go. It's coming up.
It's not uncommon for us to encounter a patient with congenital heart disease coming for a non-cardiac surgery. So it should be a multidisciplinary approach to these patients with the involvement of the cardiologist, the interventional cardiology department, and with a good ICU backup to safely anesthetize these patients. It's preferable to plan these procedures early in the day when we have adequate support available in the hospital, and an anesthesiologist with a good understanding of the cardiac pathophysiology would be more successful handling these patients. Not to mention that advanced life support, which is handy in the hospital, is very important. Now, coming to the categories of patients that we see here, now we could have patients with a corrected physiology, as in a total corrective surgery, or a partial physiology, where the correction is only partial, or who is on the way to corrected physiology, as in palliative surgery, or patient who is totally uncorrected, as in tetralogy of Fallot coming for abscess before the corrective surgery. Now, the mortality and the morbidity during the perioperative period or during the postoperative period is highest when we have an uncorrected physiology or in patients with partially corrected or with a palliative surgery. So, the single ventricular physiology, LVOT obstruction, the cardiomyopathies, and patients with isomenous or suprasystemic pulmonary hypertension. These are the patients with the highest risk of perioperative cardiac morbidity. Now, risk stratification is important to understand and prioritize the hospital services that are reserved for these patients. So, this is an article published in 2013, which stratifies the risk irrespective of the age group, that is whether it's a pediatric or an adult, by using a certain parameters as the complexity of the CHD, the current status of CHD, the outflow, the ventricular system alignment, the pulmonary vascular resistance, the current cyanotic condition, and the arrhythmias and the drugs the patient is on. Now, anybody who scores less than 6 come into the mild category, where it can be anesthetized with minimal facilities reserved for this patient, and anything more than 7 comes to moderate to high risk category for postoperative morbidity and mortality. Now, understanding the pathophysiology, I think Dr. Hema has made my talk a bit easy. So cardiacs fit into these 4 categories, like the balance between the pulmonary flow and the systemic flow, if any obstruction to the outflow from the ventricles, and its effect on the myocardial contractility and the rhythm. So it's very important for us to understand these things before we anesthetize a patient for a non-cardiac surgery. Now, again, coming to the timing and logistics, high-risk surgeries should be performed in centers which have a good cardiac intensive care unit and a cardiac support team, including a cardiothoracic surgeon. And elective and non-urgent surgeries should be reserved to patients with a stable physiology, and very stable physiology patients qualify for daycare. Otherwise, it is advisable to do it in a higher center. Now, coming to the evaluation of these patients, apart from the routine preoperative evaluation, we should have a thorough understanding of the previous cardiac history, including the procedures that the patient has undergone in the past, and any investigations like a cardiac catheterization and the results of that previous echocardiogram. These should be studied thoroughly so that we have a fair understanding of what's happening with the patient, and if required, a fresh echocardiogram should be performed before the surgery to see if the condition has deteriorated or remains the same during the period. So the importance of other blood investigations were mentioned by Dr. Hema in a talk. Now, coming to preparation of these patients, these patients could be on cardiac failure medication, which has to be continued perioperatively. And ACE inhibitors and ARB inhibitors, there is a dilemma regarding this, but if there's a lot of fluid shift expected, so these are preferably avoided during the perioperative period. Antiplatelets and anticoagulants should be discontinued appropriately, and conditions with patients who come in for dental procedures or urogenital procedures with a break in mucosa, or for endoscopic procedures, will have to be given infective endocarditis prophylaxis. Judicious use of sedative premedication. Dr. Hema, the importance of premedicating this kids, especially TOF, to avoid cyanotic spells. But at the same time, we should also be aware that the over-sedated kid or a kid with a respiratory depression can equally deteriorate even before the anesthetic has started. The air-free IV infusion system is mandatory for these cases. Now, coming to the injection, most of these cases can be induced with sevoflurane, or induction. Children can be induced by inhalational anesthetics. So IV induction could be kept reserved for patients with a compromised myocardial reserve, and propofol should be very cautiously used, especially if the patient has a compromised reserve. Etomidate, again, could be a drug of choice, but if you're expecting post-operative turbidity, then it is better to avoid that because it can significantly cause adrenal suppression even with a single dose. Coming to the goals of anesthesia, during these cases, preserving the contractility is very, very important. Now, in conditions with reduced myocardial functions, myocardial depressants should be avoided. So, most of the anesthetics cause some amount of myocardial depression. We should have measures to correct them. In the sense, we should have an inotropic backup. And maintaining adequate coronary flow, especially in cases with diastolic runoff, maintaining adequate coronary flow will improve the myocardial contractility, so it becomes very important. Now, coming to the choice of anesthetics, halothane is hardly used nowadays. So, if anybody is still using halothane, it is advisable not to use it. It's better to prefer isoflurane or sevoflurane over a halothane, but sevoflurane has a better profile as compared to isoflurane, so it's preferable. So, use of opioids should be judicious, and instead of propofol, using opioids is encouraged, especially in conditions with DORV, hypoplastic left heart, dilated cardiomyopathy, or other cardiomyopathies. It is important to preserve the myocardial function. Coming to the stents and the factors affecting the flow, it is important to maintain the direction of the stent favorably during the intraoperative period. Now, shunts can be either in the ventricular level or the atrial level or the extracardiac. But it's very important for us to have a favorable flow. So, fine balance between the PVR and the SVR is important in maintaining the shunts. So, if there is a pulmonary hypertensive crisis, it's very, very important to act. It can lead to perioperative cardiac problems, or it's got a very high chances of perioperative cardiac arrest. Now, coming to the crisis management, there could be few. We need to act immediately and to prevent further complications during the procedure. One such is pulmonary hypertension. As mentioned in the previous slide, increasing the oxygenation, reducing the carbon dioxide tension, correcting the acidosis. These things can significantly reduce the pulmonary vascular pressures. In addition to this, inhalational nitrous oxide, phosphodiesterase inhibitors can improve the pulmonary flow and reduce the pulmonary artery hypertension. Not to forget that RV contractility has to be maintained during these conditions, because acute overload on the right ventricle can cause an acute right ventricular failure. So it's important to inotropically support the right ventricle and to increase the SVR to maintain a coronary perfusion. And the cyanotic spells, or the TED spells, what we call, I think Dr. Him, the management of that, calming the child down, beta blockers, and increasing the SVR using peripherally acting vasoconstrictors. LVOT obstruction, as in cardiomyopathies, the best thing to see. LVOT obstruction can occur in cardiomyopathies when the ventricles, the volume stent or the pressure stent of the ventricle is taken out. So it's very important to keep the ventricle preloaded in these cases. Coming to cardiomyopathies, most of the cardiomyopathies, it's very important to preserve the contractility, and especially in dilated cardiomyopathy, patients could be tachycardic as a compensating mechanism. So correcting the tachycardia, overcorrecting the tachycardia and trying to bring it back to normal is not advisable in these patients. Preventing hypotension is very important, that can preserve the myocardial function. We should have a low threshold for inotropes in these cases. In an obstructive cardiomyopathy, as we already discussed, it is adequate preload, since it's a volume stented ventricle and a pressure stented ventricle, and maintaining the SVR is very important. tachycardia can be detrimental in these cases. Cardiomyopathies have a very high risk of arrhythmias and failure. So antiarrhythmics and defibrillators should be handled in this. These are one of the most important causes for sudden cardiac deaths. So coming to specific procedures, so most of these patients come for a sedation or anesthesia for imaging. So most of these cases could be handled using ketamine midazolam combination or ketamine propofol combination. The cardiac depressant effects of propofol can be counteracted by using ketamine. We should also be aware that sometimes these cases might require a general anesthesia in the MRI suite, where they have to be still for a longer time. In such situations, inhalational anesthetic along with ketamine-based induction is preferable. Similarly, for dental procedures and endoscopic procedures, ketamine-based anesthesia with inhalational maintenance is preferred. Coming to the anesthetic consideration with special surgical conditions like a pneumoperitoneum. Nowadays, most of the surgeries, abdominal surgeries or gynecological surgeries, are done laparoscopically. Pneumoperitoneum has a significant increase in the SPR and the reduced venous return. So in these cases, it is for Fontan pathology, where the venous return, systemic venous return determines the pulmonary flow, where it bypasses the ventricle and determines the pulmonary flow. It's very, very important for us to select the patients for the pneumoperitoneum, and it's very important for us to discuss with the surgeon that at any point of time, if there is a decompensation, we should have a very low threshold to move on from a laparoscopic procedure to an open procedure. If at all we do these procedures, and if the patient remains stable during these procedures, the peritoneal low hemodynamic perturbations. Other conditions where we use a tourniquet. Tourniquet has a similar effect to that of a pneumoperitoneum, but at a lower level. But when we are using a lower limb tourniquet, systemic vascular resistance can significantly increase. And during the tourniquet release, again, the acidosis can significantly affect the hemodynamics. Head low and head up positions should be used cautiously. And procedures which have the high risk of air embolism, the procedural position should be discussed with the surgeons. Example, sitting craniotomy, where the chances of air embolism are very high. We should think of alternative procedures, positioning for these procedures. And it's not very uncommon to see a congenital heart disease patient who's pregnant. Now, we already have an altered physiology in pregnancy. There is a reduction of SPR, there is an increase of plasma volume, a reduction of the pulmonary vascular resistance. So it's very important for us to understand the physiology and its effects on the existing congenital heart disease. WHO has come out with a classification for risk stratification of these pregnant patients. In my cases, pregnancy could be uneventful and it could be delivered in not an expert setup. So cases like pulmonary stenosis, mild pulmonary stenosis, patient ductus arteriosus, unrepaired AST or a VST, which are small, or a repaired tetralogy of Fallot. These cases could still be managed in a non-cardiac setup, but in a slightly complex physiology, as in ventricular impairment, when there is a mechanical valve, cyanotic this one category for pregnancy is not recommended, but it is see these patients full-term pregnancy. Right through the pregnancy, they would have a significant hemodynamic perturbation, and these are the patients whom we expect to have significant post-operative morbidity and mortality. And to end this, I would like to quote from Hensler Martin.
Thank you, Dr. Lokesh, for that excellent presentation of non-cardiac surgery in congenital heart disease. We will get the questions at the end of the session. So I request Dr. Keshavamurthy to introduce the two other speakers. We have two more short topics. Dr. Keshavamurthy, can you unmute yourself and introduce the next one?
Yes, sir. Unmuted. Good evening, everyone. I have the pleasure of introducing Dr. Prakash, our young and energetic pediatric cardiologist, performing almost 3 to 5 interventional procedures in pediatric cases. And I have been a part of it with many of the lines being accessed for them to do the procedure safely and quickly. So Prakash is trained in Narayana and he has been a consultant here with us. So over to Dr. Prakash to talk about interventional procedure in pediatrics.
Thank you, sir. Thank you for the kind introduction. First of all, at the outset, I want to thank ICA for giving me this opportunity. Unfortunately, I just want to tell that my camera is not working. Other than that, I think things are on the right turn. So first of all, thanks to my teachers, mentors and teachers initially and now my senior colleagues for what I am today. So I'll just I would like to run you through all the myriad of interventional procedures which we do in congenital heart diseases. So I would start with a few uncommon and critical ones, but because common lesions are regularly discussed in all platforms and the flow may not be in any orderly fashion, but it's just in a way to evoke interest and thought so that there is a direction for newer innovations. I also want to thank our anesthetic team and the pediatric CTVS surgeon for helping us to think and open new doors and windows to the heart and all its collateral vessels. So the scope of interventional procedures, as we all know, as already discussed about the left to right shunt, increased pulmonary circulation, device closures, balloon valvoplasty of the left ventricular outflow or right ventricular outflow, tract obstructions, and coactoplasty or stenting, and a few palliative procedures which are very difficult to perform but gives a on-table improvement of the child's condition. That is few of the newer techniques are the percutaneous pulmonary valve implantation, which we do in post intracardiac repair for TOF. Balloon atrial septostomy, which is commonly done in transposition of great arteries with restrictive interatrial communication with intact ventricular septum. Balloon coactoplasty in infancy is generally a surgeon's forte, but in cases where the child lands up in cardiogenic shock and you cannot open the ductus to stabilize him, or there is severe LV dysfunction where you have a doubt that any amount of afterload reduction or increase can lead to cardiac arrest. So such cases we generally do coactoplasty. As already, I think in the background, there's a discussion on collaterals. We generally in our center, if there are any discrepancy between the clinical findings and the echocardiographic findings, that is the echocardiographically, there is hardly any pulmonary flow, but the child or the patient is quite pink, not very cyanosed, then we know there is some additional flow, pulmonary flow. So we look for it in a CT scan before the patient lands upon the OT table. So we coil embolize them pre-surgically only. And a few palliative procedures where we are going hand in hand with our surgeons is RVOT stenting for TOF or PDA stenting in cases of single ventricle or pulmonary atresia, ventricular septal defect cases. Couple of cases of interventional Fontan we have done thanks to our surgeon, Dr. Sudesh. It was his experience and brainchild in our institute. And pericardial effusion tapping, because we have a full and running unit of pediatric hemato-oncology. So a lot of patients we get with post chemotherapy who end up with cardiac tamponade and BT shunter coil collateral embolization in relevant cases. So I'll just run through a few of them. So the challenges in interventional procedures are mainly the access to the heart or the lesion. So I was already told our well equipped team of pediatric cardiovascular surgeon, our anesthetists led by Keshavamurthy sir, and interventional radiologist we have called a few times, and also vascular surgeon to bail us out in cases of any complications. So there are lots of access to the heart, the common being femoral access of artery or vein, and also internal jugular vein. But we have already started adding hepatic vein for ASD or ventricular septal defect device closures, carotid artery for PDA stenting or coarctation stenting in a few cases, and also subclavian artery for PDA stenting. And we have done at least about, I think, 70 cases of perventricular device closure where the child is very small and ventricular septal is too big so that we cannot manipulate such big sheets to accommodate the inside the heart for those larger devices. So we end up doing sternotomy and puncturing his right ventricle, crossing the VSD, and then deploying the devices. So, and the increase in the knowledge of the hardware and variable devices, balloons, and sheets available, I think presently the interventional procedures is only just going to increase. So to discuss a few cases of interest. So this is the first one, the balloon atrial septostomy, where the child it generally can be done on a bedside under ultrasound guidance, but we generally do it under fluoroscopy because the time to procedure would be shorter. So we cross from the IVC side RA across the restrictive septum into the left atrium, inflate the balloon and give a whiplash so that there is tear of the septum. You can see right internal jugular vein generally forms a guide for us in the AP shot of the fluoroscopy. So this is one of the interesting cases. Couple of them we are done. So interventional fontan, where the surgeon keeps the stage 1 interventional fontan, where it's a single ventricle palliation where he connects the SVC to the pulmonary arteries and also the IVC through a conduit, but he and connects to the pulmonary artery, but keeps a patch across it so that you can see the IVC is still draining to the RA. So interventionally, we can perforate this membrane. And once we had perforated, you can see we could perforate with a usual septostomy needle and then balloon that and stented it. So post stenting, you can see that. So it's one stage less, sternotomy procedure for the patient and also the surgeon. So in cases from 3-stage surgery, probably we can do one open heart surgery and 2 interventions. Like we can do a ductal stenting as a first stage, and second stage, the surgeon opens the sternum and does a stage 1 interventional fontan. And again, we do the stage 2 interventional fontan. So it will be only one sternotomy procedure and 2 interventional procedures as compared to a classical single ventricle palliation where all 3 has been happening in the operating room. So this is one of the rarest conditions, that's pulmonary atresia intact septum. So you can see the right ventricle, there's no opening, the valve is doming, but there is no opening in the pulmonary valve. Again, here you can see with this injection, right ventricle has a dead end and the pulmonary artery is supplied by the ductus arteriosus. So we take orthogonal views, and by interventional procedure, we can perforate the imperforate pulmonary valve and serially dilate it to get a very satisfying result of antegrade flow without having to palliate the child surgically like a BT shunt, which is generally done. And probably most of the time the child will have significant pulmonary regurgitation, which he will tolerate well. So we'll be able to do a interventional procedure, avoiding a surgical procedure of BT shunt or Brock's procedure. Sorry, not Brock's, pulmonary valvotomy. So a couple of cases where we ended up perforating the right ventricular outflow tract. So we had to open the sternum, and the surgeon sutured the right ventricular outflow tract, and perventricularly again he perforated the membrane through the right ventricle and into the pulmonary valve. So here are 3 markers. This is where the needle entered into the right ventricle. This is where the pulmonary valve is situated, and that's where the PDA is there. So it's going into RV through the perforated pulmonary valve into the PA and PDA. So we perforated with a sheath, and then we had entered the pulmonary artery, and again with a balloon we opened up fully. So again it's here again we need help of our pediatric cardiac surgeons to bail us out, and he also wanted us to bail out. He did not want to do a shunt which is not a equally physiological as compared to having a antegrade flow. So there are a few, just as a surrogate to the collaterals I am doing. This was a case of 22-year-old referred from elsewhere for mitral valve repair actually. So just on auscultation, we could hear that there is a continuous murmur. We ended up doing a CT where we noticed that there is a huge collateral coming from the aorta supplying the left lower lobe. So this was giving rise to a dilated LALV and hence the mitral regurgitation. Because of the tortuosity of the collateral, we could not enter from the femoral artery. So we ended up doing from the carotid cut down. Again, thanks to our surgeon. So this is immediately after release. Generally, this device does not have a fabric. So the immediate closure is not there, but with time it closed. And at the follow-up of 6 months, the mitral regurgitation, which was severe, had come down to mild. So we ended up avoiding a open heart surgery, unwanted open heart surgery. So next procedure we commonly see is a pulmonary valvotomy. So you can see a thick and doming pulmonary valve with a very thin opening and jet-like flow of the blood from the RV into the PA. So we generally perform it through a inferior vena cava approach in a bigger child, but in cases of infants, it's easier to access through the right internal jugular vein so that the control over the balloon is better. And crossing a smaller tricuspid valve is easier through the superior vena cava, because the superior vena cava is directly looking into the IVC because of obvious fetal reasons. So normally the fetal circulation, your SVC blood directly flows to the tricuspid valve and into the PA and descending aorta into the the placental circulation. So it's easier to cross the tricuspid valve from the SVC rather than the PA. So we end up doing from the the RIJV approach in an infant. So another common, not very common procedure is the coronary cameral fistula. Here you can see the root aortogram showing a aneurysmally dilated RCA, and which is opening into the right ventricle just below the tricuspid valve. So through a IVC approach, we cross from the aorta through the cameral fistula into the RV and snare it into the IVC, over which we push a sheath and deploy the device. So it's near complete total occlusion of the abnormal communication without compromising the right coronary artery circulation, which is associated with it. Another uncommon procedure is the aortopulmonary window. Generally, it again ends up in the surgeon's basket, but restrictive aortopulmonary window or larger aortopulmonary window, but which are quite away from both the pulmonary or the aortic annulus, is very safe to do device closures. Here it's a very restrictive aortopulmonary window, which we could access through the IVC and close it antegradally. So we cross it because we use a flow directed tipped wire. It floats across the aorta into the PA, and from there we again snare it from the inferior vena cava approach, and through the sheath we make a arteriovenous loop and we push a sheath across it and we can deploy it further. We have done for a large defect also. We have put a 8 millimeter device in a 9-month-old child who was around 4.5 to 5 kilos just recently. So again, uncommon procedure is a ruptured sinus of Valsalva and ruptured sinus of Valsalva. Here you can see the right sinus of Valsalva opening into the RV. So we again use the flow directed or floating tipped wire and cross into the right ventricle and then snare it through the IVC and deploy the device. So once the device is in place, almost 90% of the flow has reduced. Again, with time, this fabric will get clotted and it will completely occlude the flow. So next would be the common procedures, the coarctation. So anything other than the infancy, the reintervention rate for a balloon coarctoplasty versus a surgical is nearly the same. So we prefer to do a balloon coarctoplasty in a child more than 1 year of age. So here you can see the comparison. There is some tear in the intima, but that is expected. That's the way it is. Once that heals, that will generally contract a little further. So he may need a reintervention later in life. So only one single femoral artery access can be used to do the angiogram and do the balloon as well. So coarctation stenting, again, classically done from a femoral approach. So you can see a narrowing here. This is a digital subtraction angiography as compared to a normal angiogram on the second frame. So from one of the limitations of femoral artery approach is the limitation to use the sheath size. In a adult patients, the femoral artery or the common femoral artery will be big enough to accommodate 12 or 14 French sheath. As compared to that, in children, we may not have that elbow space to use a 12 French or 10 French sheath. So we ended up doing a couple of them from left carotid artery approach. Again, thanks to our surgical team for helping us. So in case of approach through a carotid artery, it's actually very easy to control the balloon and balloon stent assembly. You don't need a long sheath and you don't need 2 or 3 persons to help you. But only caveat is that you are working from a not very helpful position. At the head end, you hardly have any table space to maneuver your sheaths and hardware. So other than that, you can use just a short sheath and manipulate the stent into place and inflate. So this generally we use in children where we think we cannot use a bigger French sheath. So next is one of the commonest valvotomies we do is the aortic valvotomy. Here you can see a very thick and doming bicuspid aortic valve with ascending aorta is root and ascending aorta is dilated. So under rapid ventricular pacing, which reduces the cardiac output so that we can stabilize the balloon at the center and we inflate. And recently we have been trying to use double balloon because this will generally help. In a bicuspid aortic valve, it will generally orient itself to the two commissures so that there will be commissural tear. In cases of single balloon, we don't have a control on where the separation of the valve takes place. If it's a commissural tear, then generally the regurgitation will be less. But in cases it tears the valve leaflet tears, then it will be a problem. So this we have been using quite regularly, where we have had comparatively better results as in terms of lesser aortic regurgitation. So generally we do a VST device from inferior vena cava approach. Here this patient had a interrupted inferior vena cava. So we ended up asking our interventional radiologist to access the hepatic vein through which we did the procedure, and he generally while coming out he just coiled the hepatic vein where it entered the hepatic vein, the sheath where it entered the hepatic vein. So other access commonly used is the inferior vena cava approach, which is very common and very classical. Sometimes we have to use a right internal jugular vein approach to access lower muscular VSTs. This is the left ventricle. This is the right ventricle. It comes from the RIGV, RA, RV, and into the VST. We have also used a retrograde approach, that is just cross from the aorta and deploy from the aortic catheter. And as already spoken, we have been doing perventricular device closures quite regularly. The main advantage being it prevents bypass and all its attendant problems. So the commonest procedure we do here is atrial septal defect. Probably presently we are doing that twice or nearly thrice the number of second MAST device closures as compared to surgery. So there are very classical and very useful methods which have been devised to help us in cases where the rims are deficient. This is the standard left atrial method. This is the balloon assisted method, where we with the help of balloon, we anchor the LA disc in the LA and then deploy the right atrial disc. And then the left atrial disc does not have space to fall back into the RA. Here again, other methods like left atrial roof method, again, it's anchored onto the left atrial roof before we deploy the right atrial disc, and then the left atrial disc falls into place. The right upper pulmonary vein technique, where the device is anchored into the right upper pulmonary vein, and we use that time to deploy the right atrial disc, then the left atrial disc falls into place.
Prakash, how many more slides are there?
I think another 2, sir. 2.
Okay.
The patent ductus arteriosus we can do with only a IVC or a femoral vein puncture, where we can cross antegradally into the aorta, do the injection, and deploy the device in the same. But sometimes when the child is small or the ductus arteriosus is very big, we may need to do a injection after the procedure. So we may have to use a femoral artery and femoral vein both. A couple of slides on palliative interventional procedures. This is a case of TOF where you can see there is a significant infundibular stenosis and doming pulmonary valve, where we had deployed the valve, and with a very nice result. We could avoid a BT shunt or sternotomy or a lateral thoracotomy BT shunt. So that surgeon is happy to do a complete correction on a new chest later on. Second one is, last one is the PDA stenting, where we generally use the left carotid artery approach, cross through the ductus into the pulmonary arteries, and deploy a stent, which gives us a very good result. And this patient just came back around 2 months back. It's almost 2 years now, 1.5 years since the procedure. He was ready for a complete correction now. Last one is the pericardial effusion tapping. This again can be done in a bedside, but just for the safety feature, and because we have the fluoroscopy in-house, we use the fluoro to enter with the wire, put a sheath, and you can see the result of the same patient. Nearly 550 ml of fluid we had drained in this child. So range of interventions, as I've discussed, can only go in one direction, up. So it can increase. It is only limited by one's imagination, and it can be extended based on need and suitability. But if we are using, improvising something and doing some off-label use, always have a team at hand, have a discussion, know the procedure and hardware, know what you are doing, and most important would be consent and counseling of the patient before we take. Thank you.
Thank you, Prakash, for that wonderful presentation with so many videos. And I'm happy that anesthesiologists might not turn out jobless. Surgeons might turn out jobless with you doing more and more procedures. Thank you. And
thank you, sir. Thank you.
Now I have the pleasure in introducing Dr. Rupa Sridhar, who needs no introduction. She is a medical superintendent and senior professor from Sri Chitra Tirunal Institute of Medical Science and Technology, Trivandrum. Over to Madam will be talking about the palliative procedures in cyanotic heart disease. Over to Madam Rupa.
Is my slide visible? And am
Yes,
I
madam.
heard?
Yes, yes, it's.
Okay, I thank the organizers for giving me this opportunity to speak on palliative procedures in cyanotic heart disease. Let's walk the talk. Why palliation? And what are the categories of palliation? We'll touch on systemic to pulmonary artery shunts. We'll touch on BT shunts, bidirectional Glenn, PA banding, atrial septostomy, atrial switch operations, Fontan, Norwood, Sano shunt, aortic valvotomy, pulmonary valvotomy, and stenting for coarctation. The palliative procedures, they do not correct the congenital heart disease, but palliative procedures are required to improve an abnormal heart function. It lessens the cyanosis or to corrects the heart failure or prepares the circulation for later correction. Now definitive repair is done at a very early stage in infancy, then why palliation? When definitive repair is not an option due to anatomic causes or due to physiology dictating the need for initial palliation, then we go for palliation. Anatomic causes, example, TOF with pulmonary atresia or small pulmonary arteries. And physiology dictating, that is tricuspid atresia or any single ventricle situation where the ultimate surgery, that is BDG or Fontan shunts, are possible only after a decline in the neonatal pulmonary vascular resistance, and this can take months. Or when an intracardiac correction may carry a higher mortality risk than stage shunting and subsequent correction. Now, what are the categories of palliation? Firstly, increasing the pulmonary artery flow, but for pulmonary oligemia, that is the shunt procedures like BT shunt and bidirectional Glenn. Secondly, decreasing the pulmonary artery flow for pulmonary overcirculation, PA banding, and some stages of Norwood procedure. Thirdly, enhancing the blood admixture inside the heart, example, atrial septostomy in transposition of great arteries. And as a fourth category is other conditions such as palliation for congenital mitral or aortic stenosis, coarctation of aorta palliation, and hybrid palliative procedures for hypoplastic left heart syndrome. Now, some of the palliative procedures have stood the test of time. Which are they? The modified Blalock-Taussig shunt, Glenn shunt, and PA banding. There's a growing trend towards the use of interventional techniques with stent deployment as an alternative to surgical approach. Let's come to systemic artery to pulmonary artery shunt. What's the aim? To increase the pulmonary blood flow. Most commonly, a subclavian artery to pulmonary artery shunt is done. What's the advantage? Cyanosis is alleviated, exercise tolerance and quality of life improves. What's the disadvantage? Increased volume load on the left side of the heart after a BT shunt. What are the indications? Tetralogy, tricuspid atresia, pulmonary atresia with intact ventricular septum, few cases of pulmonary atresia with VSD, sometimes an Epstein's anomaly, single ventricle situation with pulmonary or aortic atresia, hypoplastic left heart syndrome. We may do a BT shunt in any of these conditions. Let's talk about tetralogy first. In tetralogy, when there's hypoplastic pulmonary arteries, or when there is an anomalous coronary artery crossing the RVOT, or when this tetralogy is associated with complex cardiac lesions, we may do a BT shunt prior to total repair. Now, let's come to tricuspid atresia. In tricuspid atresia, depending upon the degree of pulmonary stenosis, they may require an initiative BT shunt prior to a Glenn or a Fontan. Pulmonary atresia with intact ventricular septum, BT shunt is done to establish a ductally independent pulmonary blood flow, and later patient may go for Fontan or cardiac transplantation. In a few cases of pulmonary atresia with VSD, also BT shunt is indicated. In some cases of Epstein's anomaly, where there is functional pulmonary atresia, that is ineffective RV contractility and so hardly any pulmonary blood flow, or when there is anatomic pulmonary atresia, BT shunt may be done. In hypoplastic left heart syndrome, as a part of Norwood operation, it is done. Now, what is classic BT shunt? In classic BT shunt, there is a direct anastomosis between the transected subclavian artery and the pulmonary artery. So, or the transected subclavian artery. So end of subclavian to side of pulmonary artery. And it's usually done on the side opposite to the aortic arch to avoid pulmonary artery kinking. What's the advantage? You're not using any prosthetic material, so there's a theoretical possibility for growth. What's the disadvantage? It sacrifices the subclavian artery and possible arm ischemia. Technical difficulties during takedown, distortion of the pulmonary artery. So what we use now is a modified Blalock-Taussig shunt, where an interposed graft, usually a prosthesis, is used between subclavian artery and pulmonary artery. So subclavian artery is not sacrificed, so it is a side-to-side anastomosis. So that's a difference, classic BT shunt and modified BT shunt. Here subclavian artery, end of subclavian, here the side of subclavian is used. A few words about central shunts, where shunt is done between the aorta and the pulmonary artery. Previously, so two shunts were done, Waterston shunt and Pott shunt. They're not at all popular now. Waterston shunt is a connection between ascending aorta and right pulmonary artery, and Pott shunt is a connection between descending aorta and left pulmonary artery. Both are no longer used. Why? Because of excessive pulmonary blood flow, risk of pulmonary hypertension, and congestive cardiac failure. Now we'll come to shunts between the systemic vein and the pulmonary artery, such as a bidirectional Glenn shunt. What's the advantage? It directs only deoxygenated blood to the pulmonary artery. So there is no volume load on the heart. What's the disadvantage? Here, because the pressure head is the SVC pressure. So the PA pressure must be low for this shunt to function. So you can see in the classic Glenn shunt, there is a connection between the SVC and the distal right pulmonary artery, while the proximal end is cut off. So the end of right pulmonary artery is used. And what is bidirectional Glenn? The SVC is connected to the upper part of the right pulmonary artery, allowing the flow from the SVC to go to both sides. It flows into both right side as well as left side. And the RPA, there is no need to cut the RPA. So that's why it goes to both lungs. That's why it's called bidirectional. What's the indication? It's used as a palliation in single ventricle situations such as tricuspid atresia. And what's the aim? It relieves the ventricle of volume and hence work overload. There is no pumping chamber incorporated when a bidirectional Glenn works. So blood is flowing to the lungs passively down a pressure gradient without any pumping chamber involved. So the circulation depends a lot on the upper body circulation. Any maneuver that decreases the upper body venous return will decrease the flow in the Glenn shunt. So it's very important to maintain a balance in ventilation and to avoid any hyperventilation. I think I've already mentioned this. Now, now we come to PA banding. What are the indications for PA banding? Congenital cardiac conditions with increased blood flow, needing a palliative procedure to protect pulmonary system until complete repair or cavopulmonary connection is performed. Example, multiple VSDs, Swiss cheese VSD, or multiple VSDs with contraindication to primary repair, such as very low birth weight, or in patients with single ventricle physiology and unrestricted pulmonary blood flow, early PA banding may have to be done before you go for an eventual Fontan. What are the other indications for PA banding? In transposition of great arteries, DTGA with an intact ventricular septum, when the patient comes to you only late, that is after 6 to 8 weeks with signs of LV regression, you cannot do an arterial switch operation. So then you have to do this PA banding to prepare the LV, to train the LV. And other indication is it's done as a part of Norwood procedure for hypoplastic left heart syndrome. So the band is placed in the mid part of the main pulmonary. This is the band. It's placed in the mid part of the main pulmonary artery, avoiding injury or distortion to not only the pulmonary valve, also avoiding impingement of the branch pulmonary arteries. The systolic pressure in the distal MPA should be reduced to less than 50% of the measured aortic systolic pressure. Now, when the oxygen saturation should be maintained at 95% while the patient is breathing room air. However, if the patient is eventually going to undergo a Fontan operation, then the lowest possible distal MPA pressure that can be achieved with a 80 to 85% oxygen saturation is desirable. So if the patient is going for a biventricular repair, you band up to a saturation of 95% breathing room air. If the patient is going for Fontan, then you band up to 80 to 85% saturation. Now, something about Fontan. Fontan procedure refers to any surgical procedure that leads to systemic flow of venous blood to the lungs without passing through a ventricle. Now, creation of Fontan circulation is palliative by nature. What are the indications for a Fontan? Tricuspid atresia, pulmonary atresia with intact ventricular septum, hypoplastic left heart syndrome, and double inlet left ventricle. Now, this is the modern cavopulmonary anastomosis, that is Fontan or TCPC, total cavopulmonary anastomosis. You can see that SVC, the end of SVC, you cut the SVC and connect it to the right pulmonary artery, to the top of the right pulmonary artery. And systemic venous blood from the upper part of the body flows into the right pulmonary artery. And systemic venous blood from the lower part of the body through the IVC is also directed to the right pulmonary artery, either through inside the right atrium, that is through a conduit inside the right atrium, or through an external cardiac conduit. So these are the two types of Fontan that is done today. Now, a lot of complications can occur after Fontan operation, such as systemic and hepatic venous hypertension, portal hypertension, pulmonary AV malformations, lymphatic dysfunction, including protein-losing enteropathy and plastic bronchitis, exercise intolerance. And what are the risk factors for complication? Do not do the surgery when patients with elevated PA pressure, anatomic abnormalities of right and left pulmonary arteries, AV valve regurgitation, and poor ventricular function. So if you do surgery, Fontan in these, then you are asking for complications. Now, Rashkin procedure or balloon atrial septostomy, which we do in transposition of great arteries, is also a palliative procedure. It provides immediate palliation in small infants with TGA. Now, atrial switch operation. This is also done in TGA when arterial switch is not an option. There are two types of atrial switch operations, the mustard and the Sennings operation. In mustard operation, you are using pericardium, and in Sennings operation, you are using the atrial septal tissue itself. And using this tissue, you're creating a baffle, directing the blood from the veins, venous blood in the right atrium towards the left ventricle. Now we come to hypoplastic left heart syndrome. The objective of management in these patients is ultimately to separate the pulmonary and systemic circulations by multi-stage surgical reconstruction. There is only one functioning ventricle. So what do? You allow the RV to stay as a systemic ventricle while blood passively flows into the lungs using the Fontan principle. Since a PA pressure and PVR are high in the neonate, the Fontan procedure cannot be performed in the neonatal period. Therefore, it's achieved in 3 stages. Stage 1, Norwood. It involves atrial septostomy to ensure unrestricted blood flow across the atrial septum, ligation of the PDA, elimination of coarctation, and a modified BT shunt to supply pulmonary blood flow, neo aorta reconstruction, and aortic arch augmentation. Stage 2 is only BDG, and stage 3 is Fontan completion. So here it is, Norwood procedure, stage 1, stage 2 BDG, and stage 3 Fontan completion. Now, after stage 1 palliation for hypoplastic left heart syndrome, some deaths were reported while the patient has a modified BT shunt, but before the creation of the bidirectional gland. It was thought to be due to stenosis or obstructed shunt and propensity to develop dehydration. So in addition, this BT shunt also provides a runoff from the systemic circulation in favor of pulmonary circulation. And as a consequence of this, diastolic blood pressure was low, leading to coronary insufficiency. So Cyano proposed a RV to PA shunt using a non-valve PTFE graft. So this is called the Cyano shunt, but then it was found that the Cyano shunt also may become obstructive over time. Now about procedures that is done in the cath lab using a balloon cut catheter. You can do pulmonary valvotomy or aortic valvotomy for the relief of congenital aortic stenosis, and palliation for coarctation of aorta, intravascular stent placement for native and recurrent coarctation of aorta. Thank you.
Thank you, Rupa, for that excellent presentation. Really lovely presentation. In the short span of time, you covered the entire spectrum of palliative procedures. Now, can I request all the speakers to unmute themselves and ready for answering the questions? Dr. Belani, Keshamurthy, Dr. Martina, Hema Nair, Lokesh, Prakash, and Rupa. To start with, there was one comment about the definition of central cyanosis is reduced hemoglobin greater than 5 grams %, or oxygen saturation less than 85%. Is that right? That is a comment made by Hemant, I think. Vaikar, are you there? You can unmute and speak for yourself. Dr. Vaikar? Sanish, can you please unmute Dr. Vaikar? And someone else asked about hyperoxia test. Can anybody explain what is hyperoxia test?
I think that question about the 5 grams was because there's 3 grams was mentioned by Hema. So maybe Hema can clarify that.
I'm not sure.
Hema, do you want to clarify that? It is reduced hemoglobin greater than 5 grams is the textbook description, if I'm right. And that's what Hemant has pointed out. So
yeah, the reference that I had, it's a journal article. It had said 3 grams. But 3 or 5, I think it's not a huge difference. Basically, the message is that it's a combination of the percentage desaturation of the hemoglobin and the hemoglobin percentage, as in if it is if there is polycythemia, or if the hemoglobin percentage is higher, even on a lower arterial saturation.
Yeah, you're right. It is the absolute value of the reduced hemoglobin which is important for cyanosis to manifest.
I mean, that is the takeaway message. There is not a huge amount of.
Yes, Hemant, are you available? Then we go on to the next question. About one question was there about collaterals in cyanotic infants. I think you have replied on the chat box.
I have replied in the chat box.
Yeah. And there's one question on MAPCAS also, that also you have replied. And one question about ketamine and congenital cyanotic heart disease. Lokesh, do you want to address that one? Dr. Lokesh, are you available?
Yeah.
How about ketamine and cyanotic congenital heart disease? This was not mentioned in your presentation. Is a ketamine good choice?
Ketamine is definitely a good choice in congenital heart disease because it maintains the systemic vascular resistance.
Especially cyanotic congenital heart disease. He has mentioned CCHD, which I guess is cyanotic congenital heart disease. Sanish, can you unmute Dr. Hemant, please?
Okay, one minute.
He wants to talk. Yes, Lokesh, you can continue as he's trying to unmute him.
In cyanotic congenital heart diseases, when there is a right to left shunt, so it preferably directs the blood to the right heart. So when you require a higher systemic vascular resistance, ketamine is definitely a drug of choice.
Hello.
Yes, Hemant, tell me.
I think whenever they use ketamine, you have to know that it has, in addition to peripheral effects, it has a central effect both on the myocardium as well as on the brain. So you have to titrate it carefully to make sure that if the catecholamines are already maxed out, then ketamine will have a depressant effect because it can't increase the sympathetic outflow. So I think careful consideration has to be given when you use it.
Right, sir.
Hi, Murli.
Yeah, Hemant, you wanted to say something about this central cyanosis and ketamine and other things. So please feel free to.
Good evening. Thank you very much, Murli. The classical description of central cyanosis is deoxygenated hemoglobin 5 grams and 85% saturation. But the author said 3 grams and 91% saturation. So that's how I got confused.
No,
she clarified.
I said 91% saturation is what is described for cyanosis. And what I said about the 3% was 75% saturation at 10% hemoglobin, 10 grams percent hemoglobin, where the total deoxygenated hemoglobin content would be 3.
Okay. Thank you. Thank you very much. Thank you.
I think the key to remember is you should know what the total oxygen capacity in the blood is, which is going to be dependent on the hemoglobin concentration. And if you take that and then you have deoxygenated blood, it's that ratio that will give you the cyanosis. So that has to be taken into consideration.
But can I say that it is the absolute amount of reduced hemoglobin, not exactly the ratio. It is the absolute amount of reduced hemoglobin which is responsible for cyanosis.
Yes.
If it's more than 5 grams per cent, irrespective of the hemoglobin concentration, if the
total oxygen
reduced hemoglobin is greater than 5 grams, central cyanosis will be manifest.
Right.
That's my contention. And there was one question about beta blockers for cyanotic spells. Sanjeevani, are you there? Which beta blocker for cyanotic spell was the question?
I think Hema answered that question, that most of the kids are on propranolol already. And in the operating room, if you see it, then maybe you can grab your esmolol.
Metoprolol and give it if required.
Esmolol, whatever is available in your table. But esmolol is short acting, and since this will go away after you use it and then get the baby properly anesthetized, you should be fine.
What is the anesthetic management for interventional procedures was one question. I think Hema has replied that you have to give
Dr. Birani said we'll discuss it. I think Dr. Keshav can address that if you don't mind.
Very small neonates who are less 3 kgs or less 3.5 kgs, or children who are less than around 3 months, we tend to intubate them, especially if it is a cyanotic coming for intervention. Little grown-up children from 4 months and above, and with a about around 5 kgs, we manage with intravenous ketamine and dexmedetomidine infusion. And lines are done with local anesthesia at the groin, and they are able to complete the procedure without much complications.
Martina, do you want to give the American view?
I'm happy to. So we would typically, depending on the intervention, just like Hema said, the more invasive the intervention is, the more we tend to perform a general endotracheal tube anesthetic. So that would be our mainstay of anesthetic. In terms of what lines we add, that happens in very close communication with our interventional cardiologists. So if we can, for instance, use potentially the access that they have and get invasive arterial blood pressures, or in an emergency use their venous access to infuse inotropes, then we would not. But if their intervention prevents us from doing that, then we would add invasive lines as we, based on the risk-benefit ratio.
Yeah, that's right. I agree. There was one question on sinus venosus ASD. Was it answered?
Yes, sir, we answered it.
Okay, that's good. Are there any other questions which are not addressed? Hyperoxemia test was asked. Who will answer that one?
Not me.
I think I'll take that. So it's a test, bedside test or inpatient test to differentiate between cardiac cause and non-cardiac cause of cyanosis.
Absolutely.
So
correct.
Arterial blood pressure, PaO2 and saturations are checked in room air and 100% oxygen for 10 minutes. So if it gets corrected, that is partial pressure of oxygen goes up beyond 92 to 95 and PaO2 beyond 90 to 100. It indicates either a respiratory cause or a neurogenic cause. So if it doesn't change much, it still stays below 85 saturations and probably 50, 60 PaO2s, then it indicates that there is a shunt, right to left shunt at the heart.
Yes. I agree. There's one question from Anjula Sarkar. Can we put a device at the same time for ASD and VSD together or you have to do if the patient is aged and VSD separately. I think that's what I understand. Manjula Sarkar, you can unmute and speak out if I am not depicting your question properly. ASD and VSD together can be done.
Yes, it can be done. Multiple devices can be done at the same sitting if it is suitable.
Thank you. Thank you.
There was one question about acyanotic congenital heart disease, whether you do cardiac cath or whether you do transthoracic echo to evaluate PA pressures, etc. Martina?
Yes, yes.
So in our center, we basically evaluate any patient with congenital heart disease with a transthoracic echo. If the exam by echo still leaves questions, oftentimes it refers to whether or not there is pulmonary hypertension and what the degree of pulmonary hypertension is. And then the next question would be whether or not it's reversible, then we would take them to the cath lab. And obviously not all VSDs or ASDs are isolated lesions. So if there's more complex defects and the relation of them needs to be determined in greater extent, then that would be an indication for a cath lab exam as well.
Thank you. One thing we did not discuss in this webinar is the role of MRI, cardiac MRI, in evaluating these conditions, particularly their progress, particularly if they've had prior surgeries, and to determine what the next step should be. And so maybe in the next webinar, we should include that.
Sure, absolutely. We'll do that. Any other burning questions are there? If there are none, I would like to announce that the Indian College of Anesthesiology does these webinars every Wednesday from 7 to 9 p.m. Please join us. And we'll be doing ECMO CME on the 17th and 18th of March. That should be interesting because we involve the critical care medicine faculty as well in that. And we look forward to having you there. And I would like to thank the ICA for this opportunity and see you next week. Thank you, Dr. Belani. Thank you, Dr. Martina, Dr. Hema Nair, Dr. Lokesh, Prakash, Rupa Sridhar, and others who have contributed to this. Keshav, of course, Keshamurthy.
Thank you.
Thank you.
Thank you so much.
Thank you to ICA and thank you to the speakers and also the delegates who attended. Enjoyed it.
Thank you.
See you next time.
Speakers.
Thank you.
Thanks,
Thank you
everyone.
very
Thank you.
much.
Thanks, Ganesh.
Thank you. Thank you very much.
Thank you, Sanesh. Thank you, Sanesh. Thank you, first.
Thank you.